Okay, so it looks like everyone is here now. We can go ahead and start the webinar. Uh, Welcome to the Neurosom webinar on advances in understanding and measuring glymphatic clearance in aging. Our featured speakers today include Dr. Ruth Banka, a distinguished sleep researcher and chair of the Department of Psychiatry and Human Behavior at Wake Forest School of Medicine, who will introduce the topic of glymphatic clearance by exploring how EEG activity evolves with age. Our second speaker is Dr. Swati Lewandowski, Associate Professor of Radiology at the University of Kansas Medical Center and Director of the Haugland Biomedical Imaging Center, who will present recent MRI findings on cerebral fluid content and flow. And our last speaker is Dr. Fon Liu, who is Neurosom's Chief Technology Officer, who will discuss brain impedance measurements using the WISP device and their potential implications for extracellular space and glymphatic clearance dynamics overnight. The webinar will be moderated by Neurosom Chief Science Officer Dr. Don Tucker and will include 10 to 15 minutes of Q&A at the end. So I'll go ahead and turn it over now to our moderator and our speaker.
Great, thanks very much. So this is really work in progress. We're kind of working on how to understand what's going on and what to do next in our own research. But we thought we'd do a webinar to try to organize it to some extent. So we'll kick off with Dr. Ruth Benka, who will give us an overview of the importance of sleep in healthy aging and potentially the role of glymphatic clearance in that process.
So I'm going to just review a little bit about what we know about what happens with sleep and aging, and in particular what happens in pathologic aging, such as in Alzheimer's disease. Just to kind of review normal aging, we know that the amount of sleep we get and the EEG power of that sleep decreases as we age. Older adults may need less sleep. They certainly get less sleep. And one of the questions is, does the brain just not sort of build up a need for sleep the same way in aging as it does when we're young? Or are we just less able to sleep? And I think that's one of the things that we want to address here today, and talk about how certain types of aging, like Alzheimer's disease, actually impair our ability to sleep as we get older. Before I start, I just want to talk about the kind of the epidemiology of sleep problems with aging. And this is an meta-analysis of looking at actually pooled prevalence of sleep problems from 35 years of studies and almost 1 million participants. And basically what you see here is that overall, we have both men and women here. Poor sleep quality is experienced by about 40% of older adults, insomnia by almost 30%, excessive daytime sleepiness almost 20%, very high rates of sleep apnea over almost 50%, and then other sleep problems over a third. So sleep problems are very common in terms of their report in older adults. Now, we divide sleep up into stages of non-REM and REM sleep, which I'll show you in a moment. And some of the things that we see with aging, one of the biggest changes is there's increasing wakefulness after sleep onset. That means that as we age, we may spend more time in bed to get less sleep. We also see decrements in slow wave sleep or deep sleep, which turn out to be very important for things like glymphatic clearance. Now we can look at brain states based on the brain wave or EEG activity or oscillatory activity that occurs. And we can also map that out over the surface of the brain by looking at multiple scalp electrodes. So again, first sort of true stage of sleep, stage 2 sleep, is characterized by two brain oscillations that are only seen in sleep, which are sleep spindles and slow waves. And so the sleep spindles can either be slow or fast, but they tend to be rather central. And the slower waves, which we particularly see in deep slow wave sleep, tend to occur over frontal areas of the brain. And that's probably related to brain plasticity, because this is the part of the brain that basically we use the most. And then these stages of non-REM sleep alternate with rapid eye movement or REM sleep, sometimes called dreaming sleep, because we tend to dream more in this stage of sleep. We're going to focus a lot today, though, on non-REM sleep, and particularly slow wave sleep, because these are the oscillations that we think are most important for learning and memory, and particularly for glymphatic clearance. So this is some work that we did when I was at the University of Wisconsin, actually using Dr. Tucker's system of high-density EEG recording, and we compared the patterns of sleep EEG across the night in different age groups. And we basically looked at normal adults ages 18 to almost 65. And if we divided them up into sort of around 10-year quartiles, you can see that the general patterns look about the same, although you can start to see maybe some differences. And one of the things we could do here is to look at age as a continuous variable. And what we wanted to see is, how does absolute power in some of these important frequency bands change with age across the continuum? And I think the blue means that it decreases with age. And what we see here is absolute power in the slow wave activity band decreases pretty uniformly across the surface of the brain as we age. And other frequency bands tend to decrease more in frontal regions. Then if we look at relative power, which is of the power that you have, where is it decreasing or increasing? We see this interesting pattern that we tend to preserve power in our dominant hemisphere, in sort of some motor and premotor areas. But we see, again, this decrement, particularly in frontal areas with aging. So again, global loss of slow wave activity across aging. Now, another thing that happens with aging, and again, we're going to be learning more about this in general, is the flow of cerebrospinal fluid, which is basically flowing through the brain and clearing toxins and things out of the brain, tends to decrease in older adults, and it is linked to decreases in this frontal delta or slow wave activity, and it's related to atrophy of gray matter. So as we know, as we age, we start losing gray matter, brain cells, and the flow of CSF decreases across the night. And this is one of the things that, as we see, we think is responsible for buildup of abnormal protein. So again, normal aging summary, we have increased fragmentation of sleep, early morning awakening, and decreased total sleep time at night. We also see sometimes increased napping during the daytime. We see a decrease in slow wave sleep, both the height or the amplitude of the slow waves as well as the number. We see a loss of fast frontal spindle amplitudes and number. And then another thing, I'm not showing data on here, but one of the aspects of sleep electrophysiology or sleep brainwaves that we think is very important for learning and memory is how spindles and slow waves are coupled, or how they occur together. So spindles are generally occur on top of a slow wave, and the timing of where the spindle on the slow wave is important for cognition, as far as we can tell, and that starts to become less robust as we age. There are also changes in the pattern of sleep. We tend to become more early birds rather than late night owls as we age, and there are many more sleep disorders that occur with aging normally. So Alzheimer's disease, kind of turn to that next, is a neurodegenerative disorder, which is characterized by accumulation of amyloid beta proteins, which form plaques on the nerves, and on the nerve endings, these plaques inhibit the ability of cells to sort of transmit signals to each other. And there also is an increase of a protein called tau, which leads to tangles in the neurons, intracellular tangles, also interfering with their functioning. And so the accumulation of the amyloid plaques in the tau leads to neurodegeneration and clinical symptoms of Alzheimer's disease. We now have increasing epidemiologic evidence that sleep disturbances are highly predictive of developing Alzheimer's disease. And there were two meta-analyses. The first was a study done by Michael Bubu, now almost 10 years ago, where he looked at studies of almost 70,000 people and found that individuals who had complaints of sleep problems were far more likely to develop Alzheimer's disease, cognitive impairment, or preclinical Alzheimer's disease, to the extent that he felt that 15% of the risk of cognitive impairment was directly due to sleep problems. Another study done a little after that was a meta-analysis of almost 250,000 individuals that were followed up for almost 10 years on average. And what they found was that different types of sleep disturbances predicted different types of dementia. Alzheimer's disease was predicted by insomnia, by sleep apnea, or general sleep disturbances that people would report. All-cause dementia seemed to be more related to sleep apnea, and general sleep disturbance and sleep apnea seem to be particularly important for vascular dementia. And I just want to point out that people with Alzheimer's disease often also have components of vascular dementia, and sleep problems can contribute to both of these. So different forms of sleep disturbance may have different profiles. Furthermore, sleep disturbances that are more long-standing are more likely to lead to dementia. So chronic sleep disturbances are more predictive than more short-term disturbances. And that may be because we know that sleep disturbance is also a symptom of dementia, and the predictive quality seems to be related to sleep disturbances being around for longer periods of time. Mild cognitive impairment is sort of an intermediate step on the way to Alzheimer's disease, and this is a meta-analysis that looked at sort of objective parameters of sleep in people with mild cognitive impairment. And what we see is they have decrements in total sleep time and sleep efficiency, also loss of REM sleep, which also seems to be important for cognition and is lost in dementia, and then trends for loss of slow wave sleep. Sleep changes in Alzheimer's disease are similar to those seen in normal aging, but they're more severe, and they also include more profound losses of slow wave activity and spindle activity and reduced time in REM sleep. There is a bidirectional relationship between Alzheimer's disease and sleep. So we know from actually experimental studies, even done in normal humans and in animal studies, that prolonged wakefulness increases amyloid beta and tau pathology and decreases clearance of these substances from the brain. We know sleep loss, that actually amyloid and tau accumulation conversely disrupts slow wave sleep, and that aging in general is associated with decreased glymphatic clearance of these toxins, probably related to other changes in brain structure. This is a study from Bryce Mander, one of my former colleagues, and he shows in this example here that the more amyloid is deposited, these are individuals' brain scans visualizing amyloid deposition. in the brain, and that the more amyloid is deposited, so on the right here we have the high amyloid deposition, the more slow wave activity is disrupted. So this is normal slow wave activity in somebody with very little amyloid, and as the amyloid accumulates, there is less and less slow wave activity. And he also showed in this study that it was the loss of slow wave activity that seemed to significantly impair memory retention in these individuals with varying levels of amyloid deposition and Alzheimer's disease. We've done several studies looking at self-reported sleep and amyloid deposition. This is from a Wisconsin sleep cohort, and we looked at individuals who were still cognitively intact, but older adults at increased risk for Alzheimer's disease based on either family history or ApoE4 status, which is a genetic marker for an increased risk of Alzheimer's. And what we found is that those who complained of worse sleep were far more likely, this is in the sleep adequacy parameter, were far more likely to show increases of amyloid deposition in areas of the brain that we know tend to be affected in Alzheimer's disease. And, another subgroup of these individuals, we had CSF fluids, so cerebrospinal fluid collected, and we looked at biomarkers for Alzheimer's disease. And what we found is, once again, that individuals who complained of poorer sleep adequacy had evidence of greater not only amyloid deposition, but also tau. And that we also saw evidence of poorer sleep associated with axonal degeneration markers and neuroinflammation markers. And finally, I want to show data from a study we did, again, with high-density EEG, courtesy of Dr. Tucker's wonderful sleep recording equipment. And we were looking at the relationship between sleep markers from the sleep studies and CSF markers of amyloid, tau, and neuronal integrity and inflammation and sleep-dependent memory. And sort of put this story all together, what we found here is that we looked at markers of CNS inflammation, of amyloid, Alzheimer's pathology and neurodegeneration. And what we found was that losses of spindle activity in these basically generally cognitively still intact individuals, were not even diagnosed with MCI yet, that we saw losses of spindle activity related to markers of central nervous system inflammation and of Alzheimer's pathology and neurodegeneration. And furthermore, that the loss of spindles in this area was also associated with losses of sleep-dependent memory in a memory task we gave them to try to remember things in the morning that they had learned before they had gone to sleep at night. So we already see evidence of how sleep oscillations may be important. And the last thing I want to finish with was just sort of a related topic is, we're more and more becoming interested on the effect of drugs on dementia risk. And some of that we think may be related to the effect of drugs on the sleep EEG. So we recently analyzed data looking at the effects of zolpidem or Ambien, a very frequently used hypnotic, versus an orexin receptor antagonist on the sleep EEG of older adults with insomnia. And what we found was that zolpidem, similar probably to other benzodiazepines and other commonly used sleeping pills, actually decreased delta sleep. It increased some spindle activity, but it also increased fast activity in the brain, which we think is probably not so good for sleep. The dual orexin receptor antagonist took away wakefulness, but it really didn't do anything to the sleep EEG one way or the other. And the reason this is of interest is that a lot of older adults have sleep problems. The more commonly prescribed drugs, although we're trying to get away from that, are benzodiazepines or what we call the Z drugs like Ambien. And a number of epidemiologic studies have suggested that use of these drugs may increase risk of Alzheimer's disease. And one of the sort of interesting questions is that because of the effects on the sleep EEG? So I'm going to stop there and see if there are any questions or anything I can add with this, and I will stop sharing. Are we done with the sharing? Yeah, we're done with sharing. Don, I'll turn it over to you.
Great. Thanks very much. That was a very impressive overview. I think we might hold the questions. We've got time for questions at the end. So hang on to your questions. And I'm going to ask Dr. Lewandowski to give us an overview of the role of MRI in assessing lymphatics function.
Thank you, Don. Thank you for the opportunity and for the introduction. Can you see my slides?
We can.
Okay, then I will get us started. So I will talk a little bit about the role of MRI in understanding the glymphatic system, what we can see and what we cannot. In this respect, the field is quite still in its infancy, but it's growing very rapidly. And so my focus is on looking at different techniques and different aspects of lymphatics that we can probe with MRI. Before I start, I do want to start with a definition of neurofluids. And this refers to all the fluids in the brain and spine, such as the blood, cerebrospinal fluid, and the interstitial fluid. And this is a relatively recently coined term, it's not even a decade old. And here, this is a cartoon diagram of the brain showing the vascular system. So arteries entering the brain and then exchanging oxygen, nutrients in the tissue, deoxygenated blood going into the venules and the veins and coming out. We also assume in most of our studies that CSF is produced from the blood at the choroid plexus and is contiguous with the ISF. The second assumption is that the Monroe-Kelly doctrine holds true, that within this rigid brain wall inside the skull, there is a reciprocal balance between the volumes of blood, ISF, CSF, and parenchyma. So for example, if we see an increase in blood volume, we are going to see a decrease in CSF volume. And although the arterial venous system, which I just pointed out, is a closed loop system, it is actually really coupled to how the CSF system flows. And you'll see how this relates to some of the MRI methods that we will talk about. When we think of lymphatics, from our basic understanding, we think about the CSF and ISF fluid exchange that allows metabolic wastes and molecules to be removed from the brain. And this exchange is at least in part driven by vascular motion. And as Ruth was showing, some of it is dominant during sleep. There is another theory that was proposed in the UK, which is called as the intramural periarterial drainage, or IPAD system. And this theory suggests that brain waste is removed from the ISF, but it drains along the basement membrane of the arteries and capillaries. So it goes back to my initial point that the CSF and ISF fluid movement is critical for the removal of waste. And whichever system you consider, it really does interact a lot with the vascular system. And I have here a quote from the paper by Humberto Mestre, which says that this lymphatic system, or this clearance mechanism, is actually occurring at a macroscopic scale. So it's occurring at the level of the whole brain, utilizing the entire cerebrovascular system, the entire CSF circulation system. But it is really dependent on tiny microscopic features in the brain. And some of these are highlighted here. What we see is perivascular spaces. So you have CSF in the subarachnoid spaces in the brain, and it flows down the Virchow-Robin spaces of the arteries. The CSF then exchanges with the ISF, and this is one of the key components of the glymphatic system. The second component is the washing of the solutes with convective flow within the ISF and then draining into the perivenous CSF spaces, and ultimately draining down in the sagittal sinus along meningeal lymphatics and other areas of the brain. how do we really visualize the glymphatic system? Now, the gold standard is an intrathecal injection of gadolinium. And if you do that, which would be injecting in right below the base of the brain or in the lumbar region of the spine, we see that contrast in MRI is taken up by the brain tissue, and you will see it appear in the brain about 1 to 2 hours after contrast injection. After that, around 6 to 9 hours, we see the contrast signal increase in a centripetal fashion. So from an outside in fashion, with the contrast signal maximizing around 24 hours. So this actually is the best and the demonstration of brain-wide uptake of contrast from the CSF into the parenchyma. And this was demonstrated by Dr. Ringstad and Eide in Norway. They also showed that this uptake is actually not is very consistent across individuals. And here they show 8 healthy individuals showing a very different rate of uptake. And that could depend on the comorbidities like vasculature, the sleep profile, and any other the daily activities for the day when they were being imaged. They also did a study where they performed a similar experiment with contrast enhancement, but they scanned people with sleep and with sleep deprivation. So they injected contrast in the morning, and they scanned people every few hours. Then at night, they kept people awake or they let them sleep. And then they scanned them again the next morning, the next day, and then after 4 weeks. And here you can see that the contrast as it is taken up by the parenchyma really slows down with sleep deprivation. Another interesting thing that they showed was that the contrast is actually taken up along the periarterial spaces. So here is the arterial network. You can see the anterior communicating arteries. You can see some of its branches, and you see the CSF contrast, the contrast in the CSF being taken up in those regions. Now, what are really the challenges with such a method? It's not very easy to perform. You can't do it really in research settings or get IRB approval. You can't repeat these experiments. And as you can see, it takes about a day to 4 weeks to really map the process out. And more importantly, we are still just looking at the influx of the contrast into the brain, but we don't really know where it exits from the brain. So we have been doing some studies with OHSU with Dr. Alison Weiss, and we've used the same method but in non-human primate models, and we've shown a similar centripetal pattern of contrast uptake with intrathecal injections. We've also shown that the alpha-adrenergic antagonist prazosin improves the uptake of gadolinium in these primates. But really, do we want to go for contrast? And so our question was, are there any other approaches that can help us investigate glymphatic physiology in vivo without using any kind of invasive method? But first, we did start with IV gadolinium. So instead of intrathecal, we are using intravenous GAD. This is a very common practice that can be done anywhere and is relatively easily approved. So this was a study done in University of Florida with our collaborators, where we looked at 8 healthy individuals. They all lay awake on an MRI safe stretcher for about 6 hours. They were given a specific diet and fluid, and they were imaged pre-contrast, 1.5 hours post-contrast, 3 hours and 6 hours after contrast. And what you see here is a group map which shows the contrast uptake at 30 minutes. And you see here the sagittal sinus really lights up around really red, and the signal is in all the large vessels. 90 minutes, the signal is starting to decrease. When 183 hours, it's even lesser. But at 6 hours, we kind of see some of the signal come back. And here, just like the study by Dr. Ringstad, we show about 6 of our participants and how variable that contrast uptake was in each of the individual. So we can, with IV injections, see the change of contrast A contrast actually exchange hands from the blood to the CSF and get into the parenchyma. However, the signal is really very, very close to the noise floor. If you look at the color bar, it's almost at 1%, which is very tiny. So what we did was we used a heavy T2 weighted FLAIR image where the signal from all tissue types is null. So the gray actually represents zero signal. The eyes are negative, and that's why they look dark. And white would represent an increase in signal intensity wherever there is contrast. And here I highlight the sentence back from Humberto Mestre's paper that we are looking at really microscopic features that help facilitate glymphatic clearance. So with this technique, we were able to identify some of these features. And what we see is with an IV injection, you do see contrast uptake along the CSF spaces of the optic nerve. And then slowly you lose the signal out, so it's draining away from the nerve. You can see the signal enter the choroid plexus, and it stays there much longer. It also enters the olfactory bulb. It's actually the cribriform plate, which is one of the major areas from which glymphatic drainage occurs. So you see that here as well. And then on this side, you see the small contrast enhancement here, which is around a bridging vein that connects the brain parenchyma to the meningeal lymphatics that are outside the brain. And we see some leakiness in this elderly participant where when we start pre-contrast, the CSF is actually dark. And after the contrast, you see that this area here is becoming gray because there is more contrast and it's kind of spreading along this subarachnoid space in this particular individual. So these were the still invasive, but relatively easy ways of looking at lymphatics. What are some other ways we can do? We can study this. So a very elegant experiment was done using just simple bowl functional MRI by Nina Fultz and Laura Lewis's group at MGH. And what they did was they just looked at the bowl signal at the base of the brain at the rhomboid fossa, so in the fourth ventricle, in the CSF. And what they saw was that as a person is awake, the signal in this region is very high frequency and is very noisy. But as the person falls asleep, you see some really rhythmic, large amplitude, slow wave oscillations in the CSF. These were around 0.05 hertz, and they were attributed to changes in the blood volume in the brain, and some of it was contributed by respiration. They also showed that the strength of these oscillations was dependent on the stage of sleep, and they were absolutely not visible during awake stages. Recent studies actually showed that this 0.05 hertz is linked to the locus ceruleus activity as it transitions you from wakefulness to sleepiness, and it causes pulsations in blood vessels that are at the same frequency that was seen in this study. And then another study from New Mexico showed that these oscillations actually do relate to the clearance of metabolic waste products. And they used breath hold in Parkinson's disease patients to see if they could increase these oscillations, increase respiration, increase oscillations, and then help clear alpha-synuclein. So this is a very easy way to implement. This is very easy technique to implement and use for measuring lymphatics. And this is one of the techniques that we are using with Dr. Tucker's instrument in our ongoing study. Now, since we are measuring at the aqueduct, at the fourth ventricle, you could also look at CSF in the aqueduct of Sylvius. These two techniques are shown to be highly correlated with each other, and a simple phase contrast is very easy to do. It's also considered in some ways better than the bowl signal because it allows you to assess the direction in which the CSF is moving. Is it moving more caudocranial or is it coming out of the brain? So this may help us understand a little bit better what the CSF is doing. Now, it's important to know that we are still looking at CSF oscillations, and that's really far away from glymphatic exchange or the CSF-ISF exchange. But what we believe is higher the oscillations in the CSF or more the movement in the CSF, better the exchange would be. we've seen that the amplitude of oscillations in older adults with sleep are around, we have the CSF velocity at the aqueduct of Sylvius is around 3 centimeters per second. And after sleep deprivation, it actually does go down a little bit. We did perform PVT or psychomotor vigilance tests the morning after normal sleep and after sleep deprivation. And the larger the difference in the CSF velocity between nighttime and morning time, the better the participant performed on this PVT response time. So they were quicker and their attention was better if their CSF velocity was higher, much, much higher at night than in the morning. Another technique that we look at is called as diffusion imaging, and this is a technique that is used to sensitize yourself to motion in the brain. When we think of DTI, we typically think of water that is moving along neuronal fiber bundles. And this is water motion that is slow and is across very short distances between neuron fiber bundles. But you could also use the same technique and look at CSF water motion that is even slower and occurring over long distances, like that between the arachnoid trabeculae in the subarachnoid spaces. And I've shown here a diagram of what that looks like. This motion is quite random, so it's also called as incoherent motion that can be detected with DTI. There are experiments done by a group in Japan, and they show that in CSF, if you do diffusion imaging, you will see diffusion, but you won't get a coherent direction because the molecules are zigzagging through the brain. And so you have to make sure that you're able to capture the motion as kind of a net displacement of water molecules. We've implemented this technique and shown that the CSF motion in the subarachnoid space, so right before it enters the perivascular spaces and exchanges with ISF, does go down with sleep deprivation. And in the 10 or so individuals we saw, it was a really nice decrease, pretty much per individual. We've done this with prazosin, and we've seen a similar effect where with prazosin, this particular diffusion parameter actually goes up, and it is related to better sleep quality and less irritation and better cognitive performance. We are using this technique in our current studies with Dr. Tucker's device. And I haven't shown that result yet because we only have one participant that we've completed and the remaining 10 are being processed. But for the one participant that we did complete, we saw that with sleep deprivation, the diffusion of CSF did go down. And with his device, which enhances glymphatic function, we did see this CSF motion again come back up to normal values. And I'm very excited about it, but I don't want to stress too much on N of 1 right now. So another thing we look at is perivascular spaces. These are enlarged Werkov-Robin spaces that you see in the brain of older adults, and they're believed to play a pivotal role in exchange of CSF and ISF. Most of the times when it's enlarged, we believe that it is because either the vessel has collapsed or there is too much CSF that is stagnating inside these perivascular spaces and affecting clearance. In this study at the KU ADRC, what we found was that greater number of enlarged perivascular spaces, so higher the burden, was observed in more amyloid positive individuals than amyloid negative individuals. We also saw that higher burden was associated with cognitive impairment, and lower burden was associated with lower burden. And we have really designed this sequence to do a high resolution scan to see perivascular spaces. So in this picture, every single dot you see is a perivascular space. And we're working on automated algorithms to segment these out so we can quantify this burden really well. So in short, I went through a bunch of different techniques that we think we could combine with some of the work that Dr. Benka showed with sleep deprivation, as well as Dr. Tucker's device. With contrast, we are able to show that if you consider the contrast as a very small protein molecule, we can show that it moves from the CSF to the parenchyma and to the blood vessels. We can also show that it can move from the vasculature to the CSF, and also sometimes at the blood CSF junctions like the choroid plexus. PET tracers can also be used, and I didn't talk about them, but they can be used to show tracer movement through the brain. So we could, with MRI, especially if we don't use contrast, we think that we can look at different aspects of lymphatic physiology. One main drawback is that we cannot really observe the drainage of these waste products or contrast into the venous sinuses. So the efflux pathway of lymphatic exchange is not yet clearly mapped out by any of the imaging techniques. Most techniques like the fMRI or phase contrast MRI, they are exploiting the oscillatory nature of CSF, and which is highly dependent on the oscillatory nature of blood vessels. So a point that Dr. Benka made was that a lot of participants have vascular disease. So if they have stiffer vessels, they're going to have low oscillations. That would mean lower oscillations in CSF and lower clearance. But what we're investigating now is that probably not all oscillations are created equal. Normally, we see the highest clearance during sleep, which is around where the oscillations are around 0.03 to 0.05 hertz. Cardiac oscillations are much higher, and respiratory oscillations are also higher than what we see in sleep. So we've kind of developed this fan and fluid analogy where we think of a rotating fan as the one that's producing the waves. This brown here is amyloid debris. And if you can produce a slow, high amplitude wave, then you do have the mechanical energy to propel the debris forward. If you have really quick oscillations and very low amplitude, you can cause that debris to move, but it is not going to have that mechanical energy to propel forward and clear out. So it's still useful for clearance because it prevents the amyloid from sticking to the vessels. That's one of its properties, but it's not most useful for clearance. And then in sleep, we do have a really slow, large amplitude oscillations that help us to clear the debris even faster than what we can do during awake stages or with different kinds of manipulations. And this is what we would like to be able to measure eventually with MRIs. So with that, I would like to thank all the individuals who are involved in the work that I showed today and Dr. Tucker. And I am ready for questions or
Again, this is great, Swati. Thanks very much. We'll hold questions to the end, and I'll ask Dr. Fan Lu to present next. He's going to talk about brain impedance, some new measures that we're excited might give us another perspective on glymphatic clearance.
Thanks, Don. Okay, so I'll start the talk by introducing a construct that we use, really that underlies the summary of what we've been doing, both from a scientific and a engineering perspective, and that's glymphatic clearance capacity. And basically what that refers to is a construct that captures sleep and neurofluid dynamics and its relation to toxic waste, particularly sleep in the stage of non-REM. And how that may be associated with changes in extracellular space. And we try to measure the changes in that extracellular space by using measurements of impedances or conductivity changes. And then we summarize it, if there are these changes, as how much of the changes we observe and measure as the capacity for glymphatic clearance. And so this is our approach. First, we measure the brain activity with EEG to understand different states of brain states associated with sleep, particularly, in other words, sleep stages. And then we use transcranial electrical stimulation to see if we can modify or enhance certain stages of sleep, in this case, again, N3. And we could do that with TES by leveraging the EIT, electrical impedance tomography, to understand how current flows through the brain, through the head volume, um, and um, and then target those brain areas associated with sleep. And then we can see if we change, modify sleep stages, would we also see changes in impedance measures, which will give us a sense of how the extracellular space changes. So that's basically the framework I'll walk us through with our associated efforts. So we start with localizing the slow waves of sleep. And we use high resolution head models um, to record people as they sleep and identify these slow waves that you can see here on this left-hand side. We map it and use high resolution head models to estimate where the sources of these slow waves are within the brain. When we do that on an individual by individual basis, what we see are the generators are in anterior medial temporal and orbital frontal regions, as shown here. This is just thresholded to see the strongest regions. And so with that knowledge, what we want to do is then target that area with transcranial electrical stimulation during sleep to enhance N3 sleep by entraining the slow waves of sleep. And we could do that if we understand the various tissues and their impedances or their resistivity to current flow. And with that understanding, then we can pick or steer to the extent that that we can how current flows to our targeted areas. This is just some examples of our modeling to show if we pick certain electrodes to inject current, what would be at the scalp, what would be the current distribution in the brain volume. And so this is just ways of steering the current distribution within the brain. With our knowledge of where the slow wave generators are of N3 sleep, we can optimize the electrode configuration using, again, these high resolution head models to select electrodes that optimally deposit current to the targeted areas. Here you see an electrode here, red and blue. So this is the front of the head, and this is the back around the mastoid area. If we pass current, if we induce current to flow from here to here, we see that we get good current distribution in our targeted areas. So this is just going from the left front to the right mastoid, and this is right front to the left mastoid. And you can see again how current is distributed there. It's just sort of a note at this point is also heavy current deposited at the base of the skull here, the foramen magnum. We may come back to that. So based on those studies, we developed a sleep wisp system that really targets these in a simple way, not of just using several electrodes, which I'll show in a little bit, placed at the front of the head and at the neck in this case. So to again target the generators of slow wave, and this is what it looks like. The sleep wisp headband looks like from the inside. So you can see just a couple electrodes, EEG recording electrodes, stimulating electrodes, the reference electrode for the EEG recording, and the stimulation electrodes at the back of the neck. So this is the front. This is the back and left, right. So using this system, we wanted to determine if we can enhance slow wave sleep in the home environment. This is with adults who use the system in home, and this is basically the study structure. So they, for each night of sleep, we have there are 3 recordings. We have a baseline night, a treatment or placebo night, and the stimulation protocol starts with the stable N2 sleep, and we stimulate for 5 minutes with a 1 minute rest period, and we do that 5 times, and then we record throughout the night. And then so this is done automatically. The participant just puts on the headband, goes to sleep, and the EEG is recorded, and the system automatically detects these stages and initiates stimulation at the appropriate time. And so we can look at, we can compare the nights, the sham nights or placebo nights where they have no stimulation, and the nights where they have stimulation. And we can look at the different sleep stages, the duration of different sleep stages. This is a graph just showing the distribution of the duration of sleep stages for all participants, and the diamonds are the means. And what we see is that TES delivered at the right time increases N3 sleep, as well as REM. So then with that, we next want to measure extracellular space changes that could occur with sleep, and in particular stages of sleep, as well as the intervention in this case, whether we stimulate or not. For that, what we do is we take regular measurements of electrode impedance. So it's a standard practice when you use EEG to measure the contact, the quality of the contact with between the electrode and the skin. So you measure the resistivity of that contact. Now, depending on the pairs that are used for injecting current, just like TES, current will be distributed differentially. And so our goal is using this just standard impedance measurements, can we estimate impedance changes in the head volume, particularly the brain? And so when you take here, as I showed before, data from pairs, injection pairs that are very far, with a large distance in between, a certain amount of current does indeed go through the skull and into the brain volume, as shown here. When the electrodes injecting pairs or current injecting electrode pairs are very close, current just essentially gets shunted through the scalp, and the skull is the big barrier. And so what we do is we use that information about impedances with pairs that are far apart, in this case front to mastoid, and we subtract the impedance values of nearby electrodes. So in this case, just as an example, FP1 would be, or FP2 here, this electrode, and this is the M1 FP2 pair. And then we subtract it from or use data from FP1, FP2, which are nearby each other on the forehead, as well as the M1, M2. the assumption is those measure predominantly the skin impedance. So when we subtract it, we get a measure of how much what is the resistivity of the brain volume, basically. And so with that, and the study structure that I just showed, we can, using that measurement of impedance changes. Now, in this case, looking at the changes across the night, and this is in the non-stimulation night. Does it change? Does impedance change over the course of the night? And it looks like it does. So here is the mean for each sleep stage, wake and 1 and 2 and 3 for the different pairs. What stands out is, so this is when they're awake, impedance does change overnight, and it seems to be particularly notable for N2, N3 sleep here, and for this particular pair, the FP1, FP2, M1 pair. And so when we look at whether that's significant or not, what we find is that, yes, it is throughout the night. There is significant change throughout the night, again, for this pair, but not by the sleep stages per se, even though what we see is the biggest changes here. And this could be just at, in this study, it's about 17 participants. So the small number could be working against us in that case. Now, so that's just across the night with sleep. Now, if we had an intervention, which is the TES, and we're actually changing the duration of sleep, do we also see changes accordingly? And in this case, we compare the changes to the sham or the placebo night. So enhancing N3 sleep particularly. And what we see when we compare that difference between stim and sham for the various stages, what we see is a really big change and significantly at the N2 step or the N2 stage. And so when we look more specifically at, so that's throughout the night, when we specifically look at the window surrounding when we apply the stimulation. So 15-minute windows, 30 minutes before, 15 minutes before at onset, and 15 minutes after, 30 minutes after. And we look at the change in impedance. The biggest change in impedance that we see occurs shortly after the TES stimulation. That's really the window between N2 because we detect stable N2 and then we inject a current to entrain the N3 sleep, which would be around this period here highlighted. And what we see is it is this period, this window between N2 and N3 where we apply the TES that we see the significant and biggest changes to brain impedance. And so let me just quickly summarize what I presented. So first, we show that impedance decreases during sleep as expected if the ECS or cerebral spinal fluid volume in the brain space changes, basically increases. And so we show impedance decreases because as CSF is more conductive. We can enhance N3 sleep. And when we do that, the impedance decreases, and particularly notable in N2 and the N2, N3 transition. So back to the concept of glymphatic clearance capacity, if we can detect ECS changes, extracellular space changes, in other words, increases during sleep, And if we could can modify that with TES, meaning increasing even in a greater capacity for or greater volume of the ECS, the implication is that both TES and the ECS measure as measured or estimated by impedance measurements can be useful as clinical tools. So just in the interest of time, I'll end it there.
Great. Thanks, Vaughn. Well, this is a very exciting panel. We've had very interesting talks, and we do have time for questions now. So maybe the best procedure is to add questions into the chat. That way we can let everybody see them. So I will contribute one question to Dr. Lewandowski. Right now, with the MRI procedures that you're looking at, what do clinicians tell you about feasibility? I mean, what I see is many people are very excited to assess glymphatic clearance. And we know it's a difficult construct, and most of the measures we're using now are very preliminary. And I think, as you said, it's only the intrathecal injection that has kind of strong classical support. But what would you say if a clinician says, I want to help people early in the process, not when they've got Alzheimer's disease, but when they're healthy aging? Can I assess glymphatic capacity with IVIM, or other MRI measures? Is it at that stage that's practical, or what would you say?
Thank you, Don, for the question. That's my dream. That's where IVI will be. Is it would be useful in the clinic. That technique in particular does suffer from poor signal to noise ratio, so it is very carefully calibrated to give us the specific signal we are looking for. And the design is also very much dependent on the vendor for MRI machines. So they don't necessarily function the same way. I think we are closer to using both functional MRI and phase contrast to assess lymphatics. In some sense, they are very far away because you're measuring signal at the base of the brain and not really at the exchange site. But there are more and more studies that are coming out that are showing that these oscillations are related to clearance. They're measuring plasma amyloid, plasma alpha-synuclein, plasma tau, and there seems to be a relationship. So very far-fetched, but I think that might be the first point of entry into the clinic because these are easily available, can be done by the technologists. You don't need any training, and they are showing some relationships. There will be a lot of reasons why you see this relationship. So that question remains to be answered, but I feel those have a better chance.
Great. That's very helpful. So I see a question in the chat, and to the hosts and panelists. So I guess this is for everybody. Do you envision interventions that improve sleep quality and glymphatic function being studied alongside pharmacological therapies? And could there be a synergistic effect?
I will briefly comment on that just based on some of
Sure.
this, just based on some of the studies that we are doing. So we are doing one study with you, Don, where we are using the device that Dr. Liu talked about, where we are
Right.
doing interventions to improve the duration of N3. And the ultimate goal is to see, does it really help clearance and kind of give you the same benefits of a whole night's sleep when you aren't able to sleep that much. Right now, we have studies that are going in parallel. So we are looking at interventions and we are looking at pharmacologic therapies using prazosin, using dexmedetomidine, and trying to see if they have a similar effect. I think there could be a synergistic effect of the two, but first we need to establish individually that they are having an effect on glymphatic function.
Right. Right. And then maybe the synergistic effects could be evaluated. Yeah. Another question for you, Swati. Any suggestion on non-invasive MRI proxy for glymphatic system, such as DT ALPS, free water, or a long T2 sequence?
That's a great question. It's a controversial question too. So I will start with the DTI ALPS. So DTI ALPS is a technique that was developed by Dr. Taoka, and his logic was very well founded. What he was trying to do was measure CSF movement along the perivascular spaces. And he was trying to say that if I could measure diffusion in the space and show that it is reduced with sleep deprivation or with Alzheimer's, then we could conclude that, hey, there is an impairment in lymphatics. Now, while the logic is sound, DTI itself is limited by its resolution. So we are looking at measurements that are done at 1.5 or 2 millimeters. And so that one voxel, when we are trying to measure this perivascular signal, actually includes perivascular signal, neuronal signal, and you could get a change in DTI ALPS from increase in free water, increase in edema, increase in neuronal atrophy, or changes in lymphatics. So all of them could contribute to it. That makes it a bit non-specific. In the recent years, I think this March, there was a symposium by ISMRM, the International Society for Magnetic Resonance in Medicine, where he presented his historical biography of how he came up with this proposal and what he thinks of it now. So he himself doesn't think that it is specific to lymphatics. Lymphatics might be one component of it. So that's where we are at with that. With long T2 sequences, we have a similar issue, but there's a lot of work going on with investigators from Cornell, from Dallas, I believe, who are looking at these long T2 sequences, and they're trying to estimate the fluid content in the brain, and they're attributing that either to excess interstitial fluid or excess CSF in PVSs. And that is a good marker, but it's an evolving marker for lymphatics. We still need to prove that they are related to clearance. It's in general true of even all the measurements that I have shown that they all need to be validated in some sense that they are measuring clearance.
By actually measuring the clearance. Right.
Mm-hmm.
Yeah. No, that's very helpful. I have, let's see, a question maybe for Dr. Liu. Are you planning to include respiration gated mechanisms into the WISP?
I guess the question, it depends on what gated means, like meaning respiration measures that then could be used to gate stimulation, or just incorporation of respiration measures into the WISP as an additional data channel.
I think it's the latter, because we do see with the fast MRI, there looks to be a CSF flow that goes with respiration. So
Yeah.
as you're breathing, it's changing the intracranial pressure
Oh,
along with the intrathoracic pressure. So breathing is like a pump
yeah.
that's pumping CSF. Could you look at the impedance changes with the WISP in terms of that?
So, well, here's so it's the first one. Again, I think what I said with the first one is whether respiration can be used then to gate stimulus delivery. Is that correct?
No, the impedance response itself.
No, no, no.
In other words,
Let me just read the comment. maybe can we allow the attendee, Demerol, to turn on the microphone? We can have a little more interactive. So I can answer. Yes, respiration. A respiration belt could be easily incorporated into the WISP. We can do that. It's an easy engineering challenge. Now, using that as a gate for other things. So once you get the data, then of course you can answer the questions that Don raised. You know how that would relate to changes in impedance measures that we have. If we had the same sample, the resolution of our impedance measurements are within the time resolution of the respiration. Right now, we just take these very slow measurements every 15 minutes of impedances. So we'd have to increase that to make these measures useful for other measures that are sampled faster. Yeah, so that's the short answer to that.
Yeah. And I think the limitation is by only sampling once every 15 minutes. But in theory, the impedance could be done every millisecond.
That's right.
It can be done continuously, and probably should be actually if we're going to do this to relate it to cardiovascular as well as the respiration and the slower changes during sleep. So we clearly need temporal resolution wherever we could get it. I would say.
Right now, more important to us is implementing the faster impedance checks, because that allows to do exactly what Don just described, and also what you would like to do, Demerol.
Yep. Another question, and this is for anybody. Do you see glymphatic-related biomarkers playing a role in identifying patients that are most likely to benefit from intervention?
That's what we are trying to achieve, is find out either MRI marker or a marker with your device done, or through just sleep marker, but something that is indicative that the glymphatic system is impaired.
Yeah, that does seem to be a real key for the field. And I think the exciting thing is we can measure sleep quality in detail. We can know when somebody's at risk of impaired sleep, but all we can do is kind of guess about glymphatic clearance right now. So this is why developing the measures is a high priority. Okay, we're clearly over time. I appreciate everybody who's hung on here. I don't see any more questions, so maybe we'll call this a wrap.
Thanks, everyone.
Great. Thanks much.
Thank you.
Bye.